it talks about something very exciting. And mark my words, is something that's going to rival what we saw in immune oncology. Last 10, 15 years were the wave of immunotherapy. Now, next 10 years, you will see a wave of radiopharmaceuticals cutting across all the tumor types, theranostics, okay? So my talk would focus on beta form of ionizing PRRT. We made a huge strides. Dr. Anthony gave a lovely presentation of the strides we made in the last 30 years in neuroendocrine cancers. And this is a summary slide of those. But if you see some of the pivotal improvement that happened in both diagnostic and management of neuroendocrine cancer came from theranostics. We have our esteemed colleagues here who were responsible largely for these important landmark studies. Dr. Strasberg led the NETTER-1 study, which led the FDA approval of Lutathera in the US. And a little bit later, Dr. Simron Singh will be presenting a talk on NETTER-2, which earlier this year showed that Lutathera not only works in refractory setting, but is a fantastic treatment for more aggressive varieties of NETs in frontline setting. And beyond the trials and the data, this is a real world patient from our clinic, 60% reduction, improvement quality of life. These treatments not only work, they're simple, they're easily scalable. You know, just 7 years back, prior to FDA approval, there were no treatment, no centers giving Lutathera outside research. Today, there are over 250 centers in the US alone, right? So these treatments are, and more importantly, they improve quality of life, unlike a lot of toxic cytotoxic chemotherapies, unfortunately. But PRT is mainstream. Should we just stop now? Absolutely not. They're great drugs, but there's a lot of room for improvement. We can improve the responses, median PFS. We need to now figure out, somebody asked amazing questions about how do we sequence the therapies, because we now have so many, problem of plenty. So we're going to hash out those issues in years to come. But the talk for today is how do we improve the current beta PRT or Lutathera or lutetium-177-based PRT. So as of now, there are various clinical trials happening in US and globally looking into the next generation of beta PRT. The first one of this, not so exciting, and this is what people do in India and Australia. The data doesn't look very exciting. Toxicity, maybe a little bit marginal improvement efficacy. But the next generation of the trials, including PARP inhibitor, my friend Dr. Del Rivero and Lynn at NIH are conducting that. Combination with VEGF, both Sutent and cabozantinib is currently in phase 1 drug development. And Dr. Lowell Anthony in a bit will talk about ribonucleotide reductase inhibitor trypene, and I'll focus more on the DNA PK inhibitor peposertib. So in just 2 more minutes, you know, it's a whirlwind, we're going to talk a little bit about this brand new drug. So when I first started working with this drug, it didn't have a name. It's called M3814. Came out of Germany, from German Merck. And it's still quite early in drug development. Head and neck, breast cancer. It's a fantastic radiation sensitizer. So without any off-target effects. So what happens when you damage the DNA? There's an uprise or upspike in DNA PK protein kinases, which repairs the DNA from the double-stranded break. So if you inhibit this enzyme, you can essentially improve the efficacy of a DNA damaging agent, be it chemotherapy, radiation. So that's the concept. We tested in our BON and QGP cell models, excellent in vitro activity, and we were able to then later validate in vivo models. And this led to a multi-center ETCTN phase 1 study. The study enrolled pretty briskly between 6 sites nationally. Primary objective was to first find the safe dose of peposertib in combination of Lutathera. We also wanted to look into early efficacy signals, response rates, median PFS. We were also tied in a lot of really interesting science, dosimetry, in a pilot cohort. We wanted to look some blood-based biomarkers. We got some funding from NCI MOCA to do a deep analysis, multi-omic analysis on, and every patient had a baseline biopsy done for this. So as of now, we already have conducted and finished the first part of the study, the phase 1 dose escalation part, and we have a recommended phase 2 dose based on DLT pharmacokinetics, which we did in collaboration with Dr. Bomer lab in University of Pittsburgh. And what we were able to find is that 100 milligram BID dose for 21 days during each cycle of Lutathera was very safe. We only incurred 3 dose-limiting toxicities. 2 were actually allergic toxicities or anaphylactic reactions, with the highest dose, which we have retracted and no longer under the development anymore. And the only patient who had a DLT of a transient liver enzyme elevation was with the current dose, but it went away, and all the patients recovered pretty well. So the next step is, of course, how did these patients do? And hopefully, if Dr. Jain invites me next year, we will have the efficacy data. So we don't like to show everything in one, right? Great. And moving forward, we are going to also explore where should we develop it next. Should we explore it in combination higher grade nets? So Dr. Simron Singh will tell us about NETTER-2. Thank you so much for being here.